All right. Well, welcome. It's nice to see you all, or see your names at least. Welcome to this August 8th, 2022 meeting of the Healthcare Industry Sector Council. For the record, I am Amy Fleming. I am the Program Development and Engagement Specialist for the Governor's Office of Workforce Innovation. And we'll go ahead and get started with the roll call of voting members. And just to be, just as a reminder, we have many non-voting member participants, and there will be opportunity to engage regardless of where you are on that voting or non-voting member assignment. But we'll start with, as we need to for the open meeting, with that voting member roll call. I know that we could be missing some still jumping on here, but we'll take this and then we'll take it again in a minute. All right, so please let me know when you hear your name. Danielle Brown.
I'm here.
There you are. June Eastridge.
Here.
Hello. Joan Hall. Don't see her yet. Patrick Kelly. All right. Jerry Reeves. Shauna Tello.
Good afternoon.
Good afternoon, Shauna. And Grace Varaga Macdell. She did let me know she'll be at a conference today and won't be able to attend. All right. So we have 4 of our 7. So with that, I can hereby affirm that this August 8th, 2022 Healthcare Industry Sector Council meeting has reached a quorum. I can also confirm that the agenda and notice for this meeting was properly posted pursuant to Nevada's open meeting law, NRS 241.020. Give a minute for, I see Jerry coming in here. Hi, Jerry. We just went through roll call, so I'm going to mark you as present. Nice.
Okay, thank you.
So with that, we'll move on to agenda item number 3, which is approval of minutes. Is there any discussion before I call for a motion to approve the April 22nd, 2022, a lot of twos in there, minutes?
I move to approve.
Wonderful. Thank you, Jerry. Is there a second?
I'll second that.
This is Shauna. I second.
Thank you both. Any further discussion? Or discussion, period. All right, so all those in favor say aye, or raise your hand. These are voting members. Great, thank you. That's Shauna, Dr. Eastridge, and Jerry Reeves, and Danielle Brown. Any opposed? I don't think we have anyone. And any abstentions? All right, so please let the record reflect that the motion carries. And that is your first official vote as voting members of this council. Congratulations. I know it's a big deal. So agenda item number 4, a quick reflection and then overview of today's topic. While I do this, I do want to encourage you to use the chat. She missed her first opportunity to vote. I wanted to encourage you to use the chat to introduce yourself just like you would if you were in the room together, handing out business cards and meeting one another. This information will be shared after the meeting, so don't introduce yourself publicly if you don't want that information shared. But this is a good opportunity to say hello and connect with folks after. Please also feel free to use the chat to pose questions during the presentations. This can sometimes help just facilitate moving that piece of that along. I do want to thank you all for attending the first round of meetings, the first Industry Sector Council meeting. The feedback we received was incredibly informative and valuable. And we did hear from a number of partners that we're putting that into action right away and referencing the information that was shared here. So I just want to reiterate that that what you're able to share, your perspective, may feel small in some ways just because you're living it every day, but the value for partners present and for others in the system is just tremendous. So thank you very much for that. So the feedback that we got in that first round of meetings did vary slightly between industries, but there was an overwhelmingly common thread for the urgent demand for talent. Didn't differ much from the headlines we might hear, especially in healthcare. So we did adjust the prompts for your introductions, and I'll call attention to that as we go through. And we've invited partners to address specific opportunities to work with the populations that they serve that are traditionally overlooked. Please do be mindful of the agenda item, whether you're sharing as an employer or a partner. We know that many of you fall into both categories, but we are trying to segment the conversation, first allowing the opportunity for the employer perspective on that demand side. And then at the end of the meeting, we'll open up for partner introductions and address some of the opportunities to engage and address some of the issues that have been raised. All right, so with that, it is my pleasure to introduce Gowan's new Executive Director, Lisa Levine, to say a few words.
Thanks, Amy. Hi, everyone. Welcome. This is my first Industry Sector Council meeting, and it is the day of kicking off my third week on the job. So looking forward to working with all of you. Please know I very much have an open door policy. I see a lot of familiar names on here. Workforce development, as we know, is housed everywhere, and we all play a role, but you see what's happening on the front lines better than us. Right. And so I think the whole idea of these industry sector council meetings is so that it's really a bottom up approach and not a top down. So please, anything we can be helpful with, we've got a great team here, really trying to kind of fill this void so that we're the collaborators and the conveners of workforce development. That's my goal. We've got a great team. I know Amy agrees with me. You're in good hands. She's done a great job with these industry sector councils. But on that note, my hope for these industry sector councils is that we hear from all of you. What are your needs? What are you hearing from your partners? What are you hearing? I see some higher ed folks on the call. What are you hearing from the students and the employers that you work with to try to fill these gaps? All of that is really helpful going into the legislative session next year. It's going to be helpful. Consider us your advocate in this space. So whatever we can be doing, looking forward to working with all of you. Thank you so much.
Thank you for that, Lisa. So we'll move to agenda item number 5, which is employer introductions. We'll open it up first to direct employers in the healthcare sector. Last meeting, we heard from many of you that there is just an overwhelming severe shortage across all roles everywhere. We heard issues about dual career challenges, attracting higher level individuals when they're relocating with a partner. We heard challenges about instructor shortages, so just the difficulty in training the new workforce in healthcare. We heard about the challenges with the remote work demand, and that many in healthcare would like to work remotely, but that is a very challenging option for this industry. We also heard about difficulty maintaining wages with retention, licensure, and this is just a fraction of what was raised. So I just mentioned that to reiterate how valuable that feedback was. It was consolidated into a report that's been shared with partners widely, and we'll be taking your feedback today and doing that as well. So I'm going to put these prompts in the chat. And while I do that, you are welcome to raise your hand to queue up. Makes it a nice little easy thing to run through there. I do also encourage you to turn your camera on if you're comfortable doing that, but do be mindful that it is being recorded. But that helps with engagement and with those that are presenting. So the prompts here in the chat. Please do let us know who you are, who you're working for or representing. And then this is really important, the top in demand, hard to fill or urgent to fill roles, those things that are rising to the top for you. We did hear, I listed them out in the reports, but we heard that there are just many, many roles that are challenging. So let us know what's rising to the top for you and how that demand has changed maybe over the past 3 months or not. Please do share acute challenges or barriers to attracting or retaining talent, as you shared previously. And again, notable changes over the past 3 months. And then added here for this meeting is if you are able to provide information about talent attraction practices or resources that have been particularly fruitful, or those you would like support to work to expand, that would be helpful for us to know for this council as well. All right, so with that, I will go ahead and call on Danielle. Thanks, Danielle.
Hello, I'm Danielle Brown. I'm the general manager for Charles River Laboratories. We're a preclinical research company working in drug development. I would say our top in demand, hard to fill roles are scientific roles. So whether that's bench scientists working for our lab science group, or it's toxicologists or veterinarians. And I think that's difficult because there's a lot of competition out there. We often have to relocate people for those positions because we have to look at a wider talent pool. And, a lot of remote opportunities have come up since the pandemic, and our positions require people to be on site working in the labs or with the staff here, or the animals. So I think those are some of the challenges and barriers that the rising cost of living is also one, although I think that's leveling out a bit. It's not as crucial. So I think that's a big change over the past 3 months. We're seeing maybe some leveling out of that rising inflation in the Reno area, which is where I'm from. But I think we're seeing less challenges with entry level folks and lower level talent than we were in the past, as that kind of levels out. That was a big challenge before. And then as far as practices, I think something that we're trying to do more is to partner with local high schools and local universities and community colleges. So we have an early talent specialist that's reaching out to high schools. We're trying to partner with TMCC here on some early veterinary assistant program. We already partnered with them for a veterinary technician program. So I think trying to tap into what talent we have coming through, whether it's high school, college, et cetera, in the area, is what we've been really working on.
That's great feedback. Thank you for sharing. Other employers able to share their perspective? Yes, Dr. Eastridge.
Hi, it's good to see you again. There have been some changes since our last meeting. It seems like things have been moving pretty fast in nursing education specifically. A lot of recruitment away from Nevada. I have 3 faculty, one faculty administrator who have been recruited through search firms to colleges in different states. And so that's pretty painful. And I think that it's obvious that different locations and for-profit and not-for-profit and public and private, all of the different types of institutions that offer nursing education have different resources. And some have much deeper pockets than what we have in public higher education here. And we're just so adverse to raising tuition or fees or anything like that because of the population we serve. And I'm speaking specifically for Nevada State, but I feel like that's the case across the board in public higher education in Nevada, with an aim for diversifying and really serving the new majority, really. And so with that commitment, we're not bringing in new revenue. And yeah, we're having people recruited away. And so I have more vacancies now than I did when we spoke last. And so we're really looking at a dire situation going into the fall semester, new academic year. So non-competitive salaries, recruitment, and sign-on bonuses, both in higher education and back to clinical practice for nursing. And I suspect that there's a lot of the same going on for other professional health careers. Just in my conversations that I have with my colleagues, that I'm not just speaking for nursing here. And so that's a big change. And I wanted to put that out there.
Yeah, I'm so sorry to hear that. That's very upsetting. But thank you for sharing. I appreciate that. Jerry.
What we are seeing are a severe shortage of personal care assistants, certified nurse assistants, people at the baseline level of high interaction with very high needs patients, especially frail homebound patients, having access to care. It's hard to recruit personal care assistants when the agencies are barely eking by with the compensation that is available from Medicaid, and when they could go to work for Target or for McDonald's with a lot less hassle with changing diapers and feeding problems and those sorts of things, make a lot more with a lot less hassle. And the agencies really can't afford the newly required training on cultural competency training in order to, because the people that work in this are themselves disparities community representatives. So it's daunting to try to pay for those expensive courses, to convince someone who is themselves African American, Hispanic, poor, etc., to take 8 hours of required training on something they're not comfortable with somebody they're not comfortable with, to learn how to make $10 an hour at best, and spend their own gas money to try to drive around to multiple houses to take care of these frail patients. So that's a daunting set of challenges. The other major categories that we're really suffering are in behavioral health providers, primary care providers, and rural healthcare providers of all type clinical levels. We just simply cannot meet the need. I do medical reviews for one of the health plans, and we're finding we can't get patients placed in hospitals because there are no beds available to place them in the hospital because there are no staff to staff those beds in those hospitals. So we have some major challenges, and the absence of the COVID crisis has not relieved the severe shortage of these very high needs clinician services that we just don't have enough of, and it's hard to recruit them. Telehealth is not really solving the problem. It's not really resolving this. It's because the people that have these needs are not, don't tend to be the ones that are connected to high-speed internet.
Right, absolutely. Jerry, can you quickly introduce yourself too, and just a little context? I think there are folks that weren't on the call previously.
Okay, I'm sorry. I'm Jerry Reeves, Medical Director for Comagine Health. And that is the group that does the Medicare quality improvement and patient safety work for Nevada and several other states.
Thank you. And very quickly, just to follow up on the required course that you mentioned, is that a federal requirement?
It's a state.
Requirement? And is it
law.
specific to healthcare or is it for every industry?
It's specific to healthcare.
Great. Okay. Thank you. It's really helpful. Thank you. Joan, go ahead.
Hi, thank you. Joan Hall, I'm the president of the Nevada Rural Hospital Partners. So I'm not a direct employer myself, but all 13 critical access hospitals in Nevada are my members. They're in rural and frontier areas. As was said earlier, we have huge shortages. We held a nursing summit in the north about a month ago now. Learned that nursing educators make much less than nurses on the average in Nevada. So that's an issue. Needing clinical spots is an issue. Those rotations, all these things that we as an industry think should be so easy for the educators to solve, finding out that no, it's not. The accreditation requirements, there was a suggestion that perhaps the number of clinical staff to the number of nurses, nursing students could be, the nursing students could be increased, and people said accreditation doesn't allow that. So we had ideas from the industry that we hoped could work, and were saddened to understand truly the process. It's just not our RNs. It's CNAs, like Dr. Reeves said. We also struggle with certified nursing assistants, medical assistants in our rural health clinics. Laboratory scientists, hard to find laboratory scientists. In rural Nevada, most of those come from the Philippines. That's where we can recruit. Traveler cost were a huge impact to us during the pandemic. Those traveling agencies, we were paying $200 to $250 an hour for RNs, $80 an hour for CNAs, where normally those are maybe $18 to $20 an hour employees. So it still is an unsustainable process. What it's doing is decreasing the capacity. We don't have enough staff, so we can't admit patients like we would like to. I think Dr. Reeves also said that there don't seem to be enough beds at any given day. The Nevada Hospital Association keeps track of this. There's 500 patients who are medically cleared in the large institutions, in the tertiary institutions, that are medically cleared to go to LTACs or long-term care facilities, but those facilities don't have the staff, so they can't accept the patients. So then that clogs up the whole system. Then Renown, UMC, those other big hospitals can't accept rural transfers. So it's all a pretty scary time, I think, for all of us. Behavioral health needs, as were stated, is a huge need. We don't seem to have enough of any type of behavioral health care provider. Positively, I mean, we don't have a lot of positives because we don't have enough people, but positively, NRHP was awarded the sub-award for IFC awarded some ARPA funds, $20 million for a nurse apprentice program. And so that is limited in the type of facility that can take advantage of that, but it's all critical access hospitals, all skilled nursing facilities, the 4 state hospitals, NAMS, SNAMS, and the 2 veterans homes, and the nonprofit hospitals can all participate. Nurse apprentices are people who are enrolled in an accredited nursing school, and they have to be employed by a hospital to be considered a nurse apprentice. They can only practice to the skills that they've been educated to in their schools. But this program looked at how do we break down that barrier. I think when DHHS looked at this, there's like 900 potential nurse apprentices. How could we use them? And so this reimburses the hospital a set amount for the nurse apprentice and gives a stipend of $3 per hour to the nursing supervisor who's overseeing that nurse apprentice. Also provides reimbursement if you offer a retention bonus. And it will offer students who live further than 50 miles from the hospital that they're acting as a nurse apprentice in. It will give them a travel stipend. So that just started. We started like in June, have rolled that out. The acute hospitals, the critical access hospitals are taking advantage of it. Skilled nursing is still trying to figure that out, how to attract those apprentice nurses. And I think that is a huge need we hope to be able to overcome. Also, when you were talking about benefits, we have the Nevada Health Service Corps that is a program modeled after the National Health Service Corps, where it's loan repayment. And so in Nevada, it's a very lucrative loan repayment, tax-free, for 2 years in an underserved area, any place that's a HPSA. It's not just for MDs, it's nurses, social workers, lab techs, all sorts of people. So we run out of money. I don't run that program, the Office of Rural Health does, but they're our partner, so we call us we. They run out of money every year before we have more applicants than we have money. So we've asked the governor's office, people at the legislature, we have to lobby for this every year. It's a federal match, dollar for dollar. We get federal dollars for every dollar that Nevada puts up. So if we could increase that, we think maybe that's a way to keep providers of all kinds in Nevada and in every underserved area. Physicians, we also have a shortage of in rural Nevada. Primary care, ER, we have a shortage of EMTs. Just about you name it, we have a shortage. And so trying to stay positive, trying to find ways to entice people to come to rural Nevada, but it's a real challenge.
Joan, can I ask you, this is something we hear across industries, right, on the higher ed instructor piece, because they can make a lot more, sometimes double, sometimes even more than that in the private sector. Dr. Reeves and Dean Eastridge, and to you, are there best practices or models in other states that you all have seen on how there can be some kind of match program or incentive on the salary piece for instructors in some of these really critical positions that we should be looking at here at the state that you would recommend?
This is Jerry Reeves. I'll just mention some that I've heard of where private employers that are trying to attract clinicians to their community will sometimes help with home loans, down payments, with scholarship, reimbursements for training expenses, and some of these other sorts of where it's public-private partnerships that are solving the major challenges, either moving expenses or loan repayments or down payments on finding a house to live in. A lot of these communities, there's real severe housing shortage. So some of these other types of assistance can cover for differences in the teacher salaries or the faculty salaries, and make it more attractive to bring. We're finding that graduating residents from our training programs in Nevada are going to other states because other states are paying them loan repayments and housing down payments and travel expenses and so forth and so on.
Yes, that's exactly what we're seeing with nursing as well, nursing education. There are other benefits besides the salary itself that makes it attractive. And the other thing that I know has deterred nurses from coming to Nevada has been our failure to join the nursing compact. So when they come to Nevada, they no longer have a license to practice across state lines. And that is so limiting, especially when you're talking about professionals who end up working 2 jobs, because as an educator, you want to keep fresh on your skills as a nurse. And so most faculty do work in the clinical area on holidays and spring break and weekends. And so to have the option, especially in locations like us, where you're so close to the state line, to be able to work in different areas depending on where the jobs are at any given time. Right now, there's plenty of jobs, but there are times, when nurse faculty would need to maybe drive an hour to pick up a shift or something. So our failure to join the Nurse Compact is a big barrier for nurses wanting to come to Nevada.
And I would second that 100 times. You're absolutely right. We saw that during the pandemic, not just with nurses, but with other healthcare professionals as well. When you could just cross lines. We could get doctors from Colorado or doctors from Arizona or wherever, and they could be licensed quickly and easily. And once that emergency declaration reached its end, I will say I think nursing has been very quick to get people licensed. So they've really worked hard. I don't think it's always going to be that way, but they've worked very hard. Other professions, it is really hard. We're waiting in some rural areas for respiratory therapists who had been licensed under the emergency directive that want to work in Nevada. It's been 3 or 4 months and they're still not licensed. Physicians, the same. Physicians assistants, the same. It's not easy. I know our licensing boards say they're here to protect the citizens, but sometimes it just seems the process gets in the way. So yeah, the compact and just licensing has also been an issue for rural Nevada.
Absolutely. Thank you for that. Shauna, go ahead. I see your hand.
Hi, this is Shauna. So I just wanted to share some of our challenges in filling some of the roles. They include critical care nurses, clinical lab technologists. Nursing leadership has been it's been difficult at the managerial level. CT techs and senior respiratory therapists, which was already mentioned. And then along the lines of our physician specialties, anesthesiologists, very difficult to get anesthesiologists right now, and CRNAs. And so one of the things at the hospital what we're doing is we're looking at starting an employment model for our physicians. Currently, the majority of our physicians are employed in our ambulatory care clinics. Now we are starting to recruit and hire in different specialties, starting with anesthesiology, CVT surgeons, and orthopedic surgeons. So we're starting to go in a different direction here to secure those resources and keep them, because a lot of those specialties that I named are also required for our trauma designation. And then if we kind of layer things back to look to see why are some of those shortages starting to happen, one of the reasons, in addition to some of the other items that were discussed, is the caps that are placed on the residency slots within the state. We have such a low amount of residency slots afforded in our state comparison to some other states that have a large population. And so I know that there's efforts being done to correct that, and we've worked with UNLV to apply for some additional slots through the CMS expansion grant and also the governor's grant. But we need to continue to really work on expanding those slots as a whole. For UMC, where we have 156 slots that were afforded, and we're over capped like many hospitals. So really need to maybe place some more efforts along those lines. And then our biggest challenge right now, some of our barriers with attracting or retaining some of our talent, is market competition. So we offer, and I can just tell you one of the areas that I'm over is medical staff, and just staffing for credentialers has been very difficult, not only because they can work from home in some of this profession, but also about the time I offer them a salary, there's another competing company within the town or outside of the state that's offering them, you know, $10 more an hour. So one of the things that our HR department has done a really great job of is really outlining our great benefit package that we have in retirement plan. So while some people are looking for that specific salary amount, when they take a look at this great visual that our Human Resource Department has put together with relation to retirement and give specific examples of timeframes along with salary and age, you can quickly see that there's a lot of benefits to staying or being employed by the hospital and also staying long-term here. So that's one of the things we're trying to really do a good job, a better job of highlighting. Because the dollar amount, you know, we're a public hospital, we also have to manage those dollars very carefully. So some of the efforts that we're taking to recruit include sponsoring jobs on Indeed and LinkedIn. There's a lot of activity on LinkedIn, and we're all aggressively on there sharing all of our job postings. Also partnering with community organizations and this Starting Employee Nevada partnership. So there's a lot of efforts underway to kind of reach out within the community and also grow our own within the hospital. Lots of tuition reimbursement, and also I would say, you know, our partnerships with community college and UNLV definitely help get the staff that we need here, and then try to help them move up and support their education. Those are some of the things we're doing. One of the things that I did want to mention from another meeting that I was in that could have an impact even more on our physicians is some of the legislation that's being proposed and being discussed with relation to malpractice caps. So in New Mexico and California, they recently had some significant changes to increase the caps, and the percentage is it's enormous. What it escalates up to year 1 all the way up to year 7, and so I think this is going to have an impact on physicians, providers within our state, as well as definitely on hospitals. So just making sure that you know, there's good marketing and good public announcements with relation to how that really can affect the providers in Nevada. And some, you know, from a patient standpoint, it sounds great. You know, more dollars provided if, you know, you're injured due to malpractice. But we have to be very careful. There's a delicate balance with relation to that. And so I think that's something that we need to keep our eye on.
Absolutely. Thank you so much, Shauna.
Thank
And I
you.
know you mentioned it in there, but just for the record, Shauna is from University Medical Center, UMC. Others that are available. Oh, go ahead, Jerry.
On a positive note, we have some projects going on within our area health education centers to expand the exposure of K through 12 students to health-related careers through VR headset, surround sound kinds of experiences, so that they can see what it's like at a Title I school where there may not be adequate resources for school counselors or career, technical academy kinds of programs to introduce them to health-related careers, all the way from personal care assistants, CNA level, up through more advanced levels. Just seeing young people that are doing something that seems like that'd be feasible for me to do if I'm in a Title I school, and I've never even thought about that as a possible career possibility, opens new opportunities. We do need more funding and more support for this, but we've had very good cooperation from the clinical simulation centers and from our board members for our area health education centers. So I do think that there is hope for our younger workforce pipeline, which is our future.
Absolutely. Thank you for sharing that resource or that update. Are there other employers or those that work closely with healthcare employers that would like to add to what's been mentioned or amplify some of what they've heard so far? So your last call for employer demand side introductions. Well, thank you all for sharing. Just as in the first meeting, this is really incredible level of detail and context here for us to be able to share with other folks within the system and hopefully try to address some of these, especially the specific issues. And I'll be following up with some of you with the resources that you've shared in hopes that we can share that out more broadly to the council. All right, so with that, we will move. We're going to jump to agenda item number 7, given some scheduling considerations, which is partner presentations. I'm looking for Dr. Minev from the Department of Corrections, which I don't actually see him on here. All right. So we'll move to, I'll recognize Gracia Perez Rodriguez, Skilled Immigrant Program Officer with the Nevada Governor's Office of New Americans, to share some of the resources in that office.
Hi, thank you, Amy. Thank you, everyone. It's been amazing to hear you all and to get a deep understanding of the healthcare sector here in Nevada. I am fairly new to my position and I'm still learning. So I appreciate the opportunity to be here. As Amy mentioned, I work for the Governor's Office for New Americans. Our office is fairly new, was created back in 2019. At the beginning of the office creation, they focused a lot of on COVID response, but now we're trying to get back to what we were created for. Our office mission is to provide the new Americans, the new Nevadans, the tools that they need to be successful. One of the things that we are working on is workforce development. As a few of you may know, a lot of the immigrants that are here in Nevada come here with foreign credentials. There's a lot of brain waste when it comes to our immigrants. When they come here, unfortunately, for them to practice medicine, whatever they came with from their home country, it is hard because you have to go back to school. Sometimes your credentials are not valid here. So we are trying to work with those groups to create pathways for them to go back to what they love. In this case would be healthcare. And I would like to share that here in the South, we have noticed with our Cuban entrants, there's great talent. A lot of them come with healthcare education, but they haven't found the way to get back to what they love. So back in 2021, they made a poll with 30 Cuban entrants. And from those 30 people that they interviewed, they identified 19 professionals. And from what we have is biomedical engineers, nurses, physicians, surgeons, cardiologists, etc. Their interest is to get back as nurse assistants, medical assistants, physicians, lab technicians, etc. So what we're doing is we're working on a 4-year strategy plan with other agencies to build a pathway for them. Obviously, for them to go back, for example, to be physicians, there's a long road ahead, but we want to work with you guys to see how can we integrate our immigrants to the workforce, to those vacancies that you're talking about. Most of them obviously are taking English as second language. They still don't have the English level required to probably go back to school, but we want to work with them because they already have the knowledge. So maybe we can open the conversation to do some internship once we get them to a medical assistant, right? Or see how else can we help them get into those jobs and help them create the pathway that they want. A lot of them, they don't want to stop with a medical assistant. I've heard a lot of them that they want to go back to their specialty. So there's a lot of talent out there, but we need to invest in them. So I know I've been hearing that it's hard for you guys to retain the talent, but the talent for at least for immigrants and refugees is already here. We just have to help them develop, and then you'll have them filling out those positions because they are here to stay with their families because they have their support system here. For them, it's harder to go to another state and try to resettle there because this is what they know, and we want them to stay here, and we want to create those opportunities. I don't want to get in an Uber and talk to someone from Cuba or Latin America and tell me that they're doctors, architects, attorneys, and they are doing Uber. And it has nothing to do with the job. It's just that for me, it's sad to know that the talent is out there, but we are not helping them create those pathways, or we are not giving them the tools in order to do what they love. So I would love to hear more about what you guys are working on. We are working with Catholic Charities here in the South to find the talent, and we want to focus on healthcare because I know there's a great need for that, and also our talent is what they want. They want to go back to healthcare. So hopefully we can work with you guys if you are interested. Please, I'm going to leave my information on the chat. I would love to talk about this a little bit more and invite you to our work group that we have. We have two work groups, one in the north, one in the south. Currently, I don't have information on our talent in the north. In the north, we have more Afghan refugees. So we are also working on that. If there's an interest, we want to help them also achieve their dreams. So thank you for the opportunity. I'm going to leave my information there. And if we can talk further, I will be more than happy.
Thank you so much, Grecia. I don't see any questions in the chat right now, but I would love to open it up if there are immediate questions that come to mind or anticipated barriers. I think this is a good opportunity to raise some of those because we know about the licensure issues, but if there are some specific areas that you think would be helpful to share or to ask of Grecia and just put that on the table, I think this is a good time to do that. Yes, Jerry, or Dr. Reeves.
I wonder if there is a way that some of these folks could work as physician assistants in offices where they really need scribes and they need people that can communicate with Hispanic populations, because not all of our clinicians speak Spanish, and especially if these immigrants are bilingual or at least can assist in that way. It might be that interfacing with the physician assistant training programs or the nurse practitioner training programs, not just the physician training programs, might offer a path to explore as something that was an innovation and a trial of a new type of program.
Yes, definitely. That's something that we are looking into, especially we know that CSN has already a program for medical assistants. So what needs to happen in order for us to help our immigrants is to understand that the barriers that they face are different from the barriers that most of us face, right? Because they already have the knowledge. They already studied, they already did residencies, they went to university. So now they come here and they have to start from most likely a lower position. But what they need to get used to is, how the system works here. So yes, definitely. I think that adjusting the programs that already exist to fill the needs of our immigrant community will be the key to integrating them into the healthcare workforce. Because as I mentioned, they already have the knowledge. They just need to be able to merge it with what it's needed here. So yeah, definitely. And we are open to hear, if you have options, if you know where we can, knock on the door, we'll do it, because we are interested in that, to provide our immigrants that opportunity to go back to what they want to do. So yeah, definitely.
Thank you for that.
Gracia, can I ask, when you have folks that come through your office, do you have a sense of what industry skills they already are bringing that we can then leverage? Is that a data tool that you have? Just thinking about how these partnerships could be strengthened from that, to Dr. Reed's point.
Yeah, we are working on that. We are working with the resettlement agencies. Right now, the Catholic Charities is working on getting us like a information on the talent that already exists, what's their background and what's the field that they want to go into, because we have a lot of people that are accountants, teachers, doctors, they want to do something completely different. So yes, we're working on that. I know we're going to get information this month on our Cuban entry population here in the South. We are working also with the resettlement agencies and theater on the North to get more information on that. But one of our goals is to figure out how we're gonna, keep the pipeline working, keep the information flowing through all stakeholders, just to understand how many do we have, how many they want to do medical assistant, how many they want to, different paths that they chose to do. So yeah, currently I don't have it with me. If I had it, I will be sharing it with you guys to give you a broad understanding of how many people we have available. But I wanted to share that information from 2021 because I think it gives you a perspective of how much talent we have out there and how these partnerships and tools are very needed in order to get them into the workforce.
Thank you for that. Are there any additional questions or comments for Gracia?
I have one.
Go for it.
Gracia, are you familiar with the process involved for transferring credits from higher education in other countries into this country? Have you seen that process at all? I know that when I was with the University of New Mexico, I reviewed transcripts from immigrants periodically, looking at credit equivalency, but I haven't seen any since I've been in Nevada. And I'm just wondering, where the hang up is with that, or if there is one. Maybe this is something that you all work with immigrants, highly educated immigrants who maybe have some credits to transfer and wouldn't have to completely start over on their education.
Yes, I have some knowledge. I'm actually a skilled immigrant myself. I came from Mexico at an older age, so I studied in Mexico and I've done it. I've done the certification. I'm an attorney, and I can tell you that it's really hard. It depends on country, the state that you study. So yes, that is something we want to look into too. But currently, due to the circumstances that our immigrants are in, they need something faster. They cannot pay those amounts to get their documents translated and then the certification. So we want to figure out something in the middle that works for them and for obviously you guys, because the other option, you need to have a lot of money and a lot of time. And unfortunately, when they get here, they need a job ASAP and they don't have the money to pay for those things. So yes, it is sad. And some of them, they came in a rush, escaping war, escaping all sorts of situations. So they don't have the documents with them. And that part, it's hard also, to go back and knock on the door of your university and be like, oh, I studied back in the 80s. Can I get my documents back? So it is really hard. It is frustrating. I finished school in 2012, and it was hard for me to do it. And, it's just a 10 years difference. So yes, I would love to explore that possibility with them if they have the documents and if we have the resources to do it. But currently, from what I know of our immigrant community, it has to be something in the middle, something where they can put the knowledge that they already have and, get them to work as soon as possible. If not, we're going to lose them. They're going to go do something else. And it's going to be hard for them to say, okay, now I'm ready to, stop working, get back into, training, and then get back into healthcare. So yeah, that's the challenge that we face, immediacy.
Yeah, absolutely. Any additional questions or comments?
Yes, this is Michael Minev from the Nevada Department of Corrections. I'm the medical director. Thanks for sending me the invite, Amy. We were able to get on. Thank you.
Yes, hi.
Hi. I just wanted to, I'm actually here with my chief of nursing, Leah Flores. And so I just wanted to ask Gracia, is there a need for, you're talking about, students that want to come back into the workforce. Do you have any need for any type of volunteer opportunities or opportunities to work in a healthcare setting? We do have those available at the Nevada Department of Corrections.
I don't have the answer for that, but we'll definitely like to talk to you about it and get a little bit more information, to also check with our talent to see, if there's an interest. And if there is, we can definitely make those connections. I used to work for the Mexican consulate, so I am very familiar with your work and, the need of medical experts there in NDOC.
Okay. Yeah.
Thank you.
Thank you.
Well, I can switch over to your presentation, Dr. Minev. Do you want me to run the slides, or is that something that you want to do on your computer there?
Yeah, if you could, that'd probably be
All
the
right.
easiest way to do it. Thank you.
No problem. So with that, let me get this shared. It's my pleasure to introduce Dr. Minev, who's the medical director of the Nevada Department of Corrections. I do want to provide some quick context before I jump over to those slides. We have had the opportunity in previous meetings in this round to hear from the Department of Corrections about the opportunities to work with individuals that are incarcerated or recently incarcerated in the workforce. But we're going to hear a little bit more about the actual demand within the Department of Corrections for healthcare professionals. So that's, I think, a special opportunity here. So let me put this up. All right. Can you see those slides? All right, great. Go for it.
Okay. Thank you, Amy. Okay. Hello, everyone. My name is Michael Minev. I'm a physician. I'm the medical director of the Nevada Department of Corrections. And just a little bit about me. I've been in this position since October 1st of 2018. I completed my medical training in Israel. I studied at Ben Gurion University. Afterwards, I completed my residency at Mount Auburn Hospital in Cambridge, Massachusetts, and then moved back to Las Vegas. And I've worked in the about 3 to 4 years in the private sector, and another 4 years at the Veterans Administration. And again, I've been working here with Nevada Department of Corrections since 2018. I really have a passion for caring for underserved populations. So I think I've really found my fit here. And I'd just like to introduce my chief of nursing, Leah Flores, and she'll just give a little couple lines about her experience and her background.
Good afternoon, everyone. My name is Leilani Flores. I'm the chief of nursing here at NDOC. I've been with the department in 2016 as a director of nursing at the women's facility here at the NDOC. I moved into the chief of nursing position in 2020, I believe. and been on this position ever since. I'm also an immigrant, was recruited in Tennessee. And then when I stepped here in the US soil, I had my green card already. I was lucky, but it did took a long time. I think it took me like 2 years to process all of my papers. Yeah, like Dr. Menev, I think I found my passion also. Been a critical nurse since 1992 after my graduation, after I graduated from nursing, and I slowed down, so this is where I am right now. Thank you.
Thank you, Leah. Next slide, please. So the purpose of this presentation, just to give a brief illustration of the overall conditions of NDOC's medical staffing, which is quite in dire need right now. We want to give two examples of two of our major institutions that best exemplify some of the staffing challenges that we have at this time. A lot of those are due to post-pandemic after, obviously we're still in the pandemic, but kind of the tail end, hopefully, of the pandemic. Provide some possible causes of some of the challenges that are now facing us with the medical department at the Department of Corrections, and show our attempts at going beyond routine job postings to obtain staff. Next slide, please. So just an overview, as of August 4th, we have almost 10,000 offenders housed in 7 major institutions throughout the state. For our staff, we have 385 total positions in our medical department. 98 positions are vacant. So we have a very high vacancy rate at this time, about 32%. Just within the second quarter, we've had 17 staff resignations. Next slide, please. So again, this is kind of looking at our medical and mental health providers. The total positions we have is 24. We have a vacancy of about 30%. You have those basically seven positions out of those 24. Almost 30% are vacant. Next slide, please. Looking at our nursing and nursing assistants, we have 200 total positions. 98 of the RN positions are filled, 43 vacant. LPNs, licensed practical nurses, we have 21 filled with 20 vacant. And then CNAs, we have 12 filled with 6 vacant. So overall, we have about a vacant position, about 35%. Next slide. So looking at our major intake facility in the south is High Desert State Prison. It's in Indian Springs, Nevada. It's about 44 miles outside of Las Vegas. We have an inmate population of approximately 3,200 offenders. And Ely State Prison, which is our maximum security facility, is about 225 miles from Las Vegas, with an inmate population of almost 700 offenders. Next slide, please.
I think there's just a little delay on it getting through. Sorry about that. It'll pop up.
No problem. So if we look at High Desert State Prison Medical, which is, again, probably our largest facility in the state, inmate population of about 3,200 offenders. We have a total medical staff position complement of 67 positions, 23 of which are vacant. And if you look at this chart here on the bottom, we have the different positions going down from DONs, which are directors of nursing, charge nurses, staff RNs, who are basically the nurses that do kind of a lot of the groundwork, the evaluation of patients, bringing medications, doing evaluations, intake, LPNs, licensed practical nurses, and then certified nurse assistants or CNAs, as well as medical practitioners. And you can see when we're looking at the currently filled versus currently vacant, we do have a very high vacancy rate, particularly of our staff RNs, and LPNs. And even with our medical practitioners, although we have 3.75 positions filled, we currently have a vacancy of 1.75. Next slide, please. So just to look at the size of High Desert State Prison, it's a 1.5 million square feet facility. The distance, just to give you kind of an idea of some of the logistics of how difficult it is for medical staff, nursing staff to travel between the medical building and other housing units, or the gatehouse, which is the main entrance portal of the prison. The gatehouse to the medical building is approximately 1,300 feet. If you look at the medical building to the closest housing unit, it's about 400 feet. Medical building to the farthest housing unit, 2,000 feet. And so you look at the nursing pill call is where, you know, nurses are assigned to bring medications out to these housing units from the main medical building. And they average about 10 to 15,000 steps on any given shift. And so it's a very taxing job for these nurses, especially when you have a very large temperature range. And there's a lot of medical acuity because of the size of the number of offenders at the facility. Typically, nurses can expect to respond to between 5 to 10 medical emergencies and responses to suicide ideation or suicidal attempts per day. Next slide, please. Ely State Prison, again, inmate population of almost 700 offenders. We have a total medical staff position roster of about 29, of which 22 are vacant. So we have a very high vacancy rate at Ely. We currently have a vacancy of 9 staff RNs, as well as 6 LPNs, which is very critical at this point. And we're having very, very difficult times of recruiting medical staff to Ely, even when we take into account trying to recruit nursing staff from agency nurses. Next slide, please. So basic medical services provided by NDOC Medical, and those include nurses, as well as dentists, mental health providers, and physicians. We also have nurse practitioners. That includes, some of the services include pill call, nursing sick call, doctor sick call, chronic clinic follow-ups for those offenders with chronic conditions that can include anything from diabetes, hypertension, chronic lung disease, infirmary care for those offenders that are ill, that might have just come out of the hospital or might have been transferred from a medical facility, man down and emergency care. Obviously, that can include anything from cardiac events, strokes, can also include altercations between offenders. Mental health care, we have a dental care unit. Intake for all new offenders coming into our facilities. Our main intake centers are High Desert State Prison here in the south. For women, we have Florence McClure, which is the intake center for all the women's offenders in the state. And then we also have an intake center at NNCC, which is Northern Nevada Correctional Center in Carson City. NNCC, or Northern Nevada Correctional Center, is also a regional medical facility where we care for our sickest offenders. We've been providing vaccination clinics, obviously more so now during the pandemic, and also laboratory imaging, which is dependent on the facility. Next slide, please. So some of the unintended consequences of our staffing shortage is we've had delays in medical care, increased incidences of medical emergencies, increased hospital transfers, increase in costs of medical treatments and procedures. And a lot of this has to do with just, there are delays in getting medical care because of the lack of staffing that are afforded in all our facilities throughout the state. This results in administrative overtime or grievances and lawsuits, which ultimately leads to more medical and agency spending and stress and burnout to all of our staff that are working in our medical departments. Next slide, please. So some causes contributing to low staffing, there's decreased community interest in correctional medical positions. That has a lot to do with sometimes bad publicity or safety concerns. A lot of the stereotypes of working in a correctional setting, kind of scares a lot of individuals out in the community from coming to join us. The slow hiring process from interview to start date is also one of the hurdles, not only with our agency, but with all state agencies. Uncompetitive pay for experienced staff, and then resultant lack of yearly salary increases for nursing staff. SMART 21 is kind of also ties into the hiring process. Obviously, there's been a lot of glitches and issues with that have kind of slowed down the hiring process. Also with retention, the low staffing with slow hiring process tends to burn out staff that are waiting for the process to proceed. We have a lot of new hires quit before they become full employees because of the difficulty and the amount of time that it requires to come on board. And the constant increased workload and minimum staffing leads to stress burnout amongst our existing employees. Unfortunately, a lot of better incentives exist in the community, higher pay, bonuses, yearly increases. And again, concerns over safety due to staffing shortages for correctional officers can sometimes result in decreased retention. Next slide, please. Mitigation efforts. We've reached out to UNLV School of Nursing and the UNLV Medical School. We are trying to recruit clinical pharmacists from Rosamond College, which is here in Las Vegas. I believe they have a Henderson campus. They hope to open up a new campus in Las Vegas. We've reached out again to UMC Medical Student for resident medical students. One of the issues that we've had with reaching out to the nursing and medical schools and the pharmacy schools is, although they do have a lot of students that do want to work for us, it requires us to provide salaries to the preceptors from the nursing, medical, and dental schools, which is unfortunately cost prohibitive for us at this time. So we're hoping to find strategies, grants, and other ways around that so that we can try to find the necessary funding that we need to get those preceptors and their associated students to come work for us. We've advertised on job fairs and other social media platforms and word of mouth recruitment. Next slide, please.
You know what? That's the last slide that I have. Yeah. Mhm.
So thank you. If I'm available, me and Leah are available for any questions you may have, or also welcome to any advice you might be able to give us and help us with our predicament here.
Absolutely. Thank you so much, both of you, for being here this afternoon. It looks like Dr. Reeves has a question. Go ahead.
Is this unique to Nevada, or is this common for all departments of corrections in all states?
Well, I'm familiar. Oh, hi, Dr. Reeves. This is Michael Mina. Thank you for your question. I do work closely with the Arizona Department of Corrections. They have a privatized healthcare system for their offender population in Arizona. So they really don't have as much of a staffing issue there because they're privatized. We've had discussions with California Department of Corrections And I know that we have at least one provider that works with the San Mateo Detention Center that we've provided some information. And because they have a lot of robust funding, they don't have issues with staffing. So unfortunately, I only have kind of direct exposure to those limited correctional settings in terms of the medical care provided in Arizona and California. But it seems as though, from my review of the literature, that it is something that is kind of becoming more prevalent, especially as we're coming to the tail end of the pandemic, particularly for state-funded medical care provided in states throughout the nation.
And have you reached out to Turo, which is the largest training program in the state, for a variety, both, for a variety of nurse practitioner, physician assistant, physician trainees, and they are always looking for clinical opportunities. And is it possible to have virtual preceptors as opposed to staff that are faculty that have to be physically in Ely or physically in Indian Springs to supervise students or residents that are in training there at your sites?
I have not reached out to Turo, but thank you very much for that recommendation. I never thought about virtual preceptorship. That's really a brilliant idea. It's something I never even thought of, but we definitely will take notes on that to mention that to the schools that we've gone out to.
Some of those might be even faculty from other states, that could be precepting virtually. So especially that you have nursing staff there that could assist with some of the clinical interaction. So just something to consider.
Well, that's a great recommendation. I never thought of that. Thank you.
Wonderful. Thank you for that. Other questions or comments? Well, great. Thank you, Dr. Manav. I appreciate you being here today.
Thank you.
All right, so our next presentation is from the Nevada Department of Veterans Services, and I don't see our contact here today. I know there was a scheduling conflict. I wasn't sure if they were able to send an alternate, so give a second to speak up if you're from the Nevada Department of Veterans Services. Okay. So with that, we're going to move to agenda item number 6, which is workforce and economic data. So last month, you got an overview, big picture, what's been happening in the state, particularly from the start of the pandemic to where we were 3 months ago. Jobs were up from pre-pandemic levels already for this industry. And the size of the industry, we heard from our experts, was comparable to the state's accommodation industry. So pretty big employers in this state. So as we turn to our presenters this month, I ask you please again, feel free to use the chat to post questions and reactions, particularly around what resonates with your experience and what might differ. All right, so with that, I am delighted to recognize Marianne Segerson, economist with the Research and Analysis Bureau of the Nevada Department of Employment, Training, and Rehabilitation.
Hello, my name is Marianne. Nice to be here and super interesting to hear everyone talk about this industry. So since I work with Dave, and I'm just going to kind of present some of the items that he would normally present. So I'm going to go ahead and get to my PowerPoint, share it. And 1 second.
And as you pull that up, Marianne, I just want to be mindful of time, since we do have a number of items on the agenda left in the next 40 minutes or so. We'll move through this, and then we have our update from GoEd, and then we'll move to partner introduction. So I just want everybody to have that context.
Yeah, sure. I'll try to go fairly
good.
or? Sorry. Can you guys see that?
Yes, we're seeing the PowerPoint view, but it's fine. Oh, and if you're able to share
Oh,
the
you're not
full
seeing
screen,
the-
yeah. Just thinking about how small some of the text can be for these.
Have it on presentation view. You're not seeing that though?
No, I'm not sure if it might be on a different screen.
Yeah.
If it would help, we can jump over to GOED's presentation and then we'll come back to yours. Oh, we'll try.
Okay, I think I got it. Maybe there is a delay with the,
Oh, possibly.
are you guys seeing it kind of larger now?
No, not yet. But this, I think this works. We can see, okay, and we'll send the slides in for follow-up.
Okay. So I'll just go ahead with it. Hopefully it will populate larger because it's kind of going big on my screen.
Okay.
Anyway, this is just kind of looking at the statewide employment. Again, we're continuing to recover. And we have surpassed the February 2020 levels. The left column shows the net change in jobs.
Oh, I'm sorry to interrupt. So what we're what we're seeing is the higher wage industries slide. So it looks like the full screen and the PowerPoint view aren't syncing. Do you want to send them over to me and maybe Chelsea can share her slides and I can put those up and share full screen? Does that sound okay?
Sure.
All right, sounds good. Okay, so
Yeah.
we'll pause on this. And I will recognize Chelsea Wahlberg, who is the Director of Business Development in the North with the Governor's Office of Economic Development.
Hi, everyone. Let me go ahead and share my screen and hopefully it'll work for me. Okay, how is that?
Yeah, we can see the full screen there.
Okay, great. Okay, so last time I I went over the health science career cluster and how that occupational group was doing in the state as a whole. Today, I'm going to just narrow in on our in-demand occupation analysis and some feedback I would like from this group, hopefully. So there's going to be a lot of slides here with a lot of definitions on them. I promise you I will not read them word for word. They're just simply there so you can have them later if you're curious what some of these inputs means. So when we look at our in-demand occupation analysis, there's several different factors that we take into account to get to that final list. So to identify the high demand occupations, we do a target sector approach. We look at real-time job postings, the Dieter occupational employment projections, Brookings STEM scores, job openings, wages, automation risk, and COVID risk. And so I'll go through each of these briefly. But as I said, the definitions are on these if you want to look further. So what I mean by target sector approach is we are focusing on GOED's key industries that were identified in GOED's economic plan for development, which a new one will be coming out in a draft form in the September board meeting. But currently those industries are aerospace and defense, most importantly for this group, healthcare, information technology, manufacturing, logistics and operations, mining, natural resource technologies, and of course, tourism and gaming. So we take all of those industries and we put them together in one big group. And then we utilize staffing patterns to transform the industry groups into occupational data. The STEM scores, I think, are pretty self-explanatory. Those come from a Brookings report in 2013. They simply are a way to identify which occupations are more or less important in terms of STEM. So if you have to have more knowledge in STEM for an occupation, you get a higher score. And if you have to have less knowledge for an occupation, you would get a lower score. So we wanted to incorporate this in a way that the higher STEM scores get a higher ranking. Location quotients. So if you don't know, a location quotient will quantify how concentrated a particular industry, cluster, occupation, or demographic group is in a region as compared to a larger counterpart. So you could compare an MSA to the state or to the county it sits in or to the nation as a whole. In our case, we are looking at everything as compared to the nation, even in our smaller groups that we do these rankings. But what that does is it reveals what makes a particular industry in a region unique. So just some finer details on that. If an occupation had less than 200 employees, we would use the economy location quotient, meaning we would use the location quotient for all occupational employment, not just from the staffing patterns we used from the key industry groups. So it would be a larger number that would give a more accurate location quotient, just because we don't want to filter out occupations just because there aren't necessarily a lot in our key industries. Just a way to normalize the data. Job postings, another one that I think is pretty self-explanatory. What I do for job postings is I would grab the most recent year's data at the time that I was creating the ranking. So in the case of these rankings, they came from May 2020 to April 2021. So we grab those for every occupation and plug them in. The wages is derived from the OES program. So that's sometimes referred to as compensation, and it consists of percentile earnings and average earnings for each occupation. So higher wages, we were hoping we could push up in the in-demand ranking. We don't want super low wage jobs to be at the top of our in-demand ranking because we want better jobs for Nevadans. But there are some cases where wages are suppressed because there's not enough data in that occupational fields for the state. So we would use national wages in those cases. Employment projections. So in our current iteration of the in-demand occupations, I actually had to use the MC now Lightcast. So I had to use the Lightcast projections. Deers just weren't up to date at that point, no fault of their own. They take a long time to do, and sometimes there's big gaps in between. I know that the newer version will be coming out shortly, so we're going to use those for the next iteration. Deeters are always better if they're available. But what we're looking for here are occupational separations and openings. I'm sorry. Those are things that are used to make MCs. We'll skip that part. If you want to know how MC makes theirs, it's on the slide. Deeter has a lot of different things that they do to create their projections. But that's just for each occupation, we're looking to see where is that occupation going? Are we forecasting more or less? The automation index also comes from Lightcast. This is another, if it's a higher score, if it's over 100, It indicates that there's a higher than average risk of automation, and lower than 100 indicates that a lower than average risk of automation is there. The idea here is I wanted to push down jobs that have a higher risk of automation. Not that those aren't important jobs, but we're anticipating that they will decrease significantly in probably the next decade or just go away altogether. For this round, there was also a COVID susceptibility index that I created in-house. That factored in a few things, UI data, unemployment insurance data, job loss and change in wages for each occupation. So I ranked those in a way that translated to a similar score to the automation index. So a ranking higher than 100 indicated a higher than average risk of COVID affecting the occupation, and less than 100 indicated a lower than average risk of COVID affecting the occupation. I don't believe we'll be including this in the next round. That will actually be up to Ms. Haley Owens, who will be taking over the research manager position. And then finally, we create the ranking. So after we compile all of that data for every occupation, we weight each factor, and those weights are determined by opinion and regression analysis to derive the most logical and optimal score for each occupation. So we use those weighted scores and for each 6-digit occupation, and then we rank them to provide the detailed in-demand occupation ranking list. So here is just the 2-digit SOC code, so you can see where that ranking kind of fell for each of the occupational groups. As you can see, the number 1 2-digit occupational grouping is healthcare practitioners and technical occupations. So I think that aligns with what all of you were talking about today. Those jobs are in demand and they are needed. So that's the ranking in itself. I apologize if I went too fast there, but I'm happy to answer any questions on any of that if you're curious. If not, you can just accept that that's how we make them. So for the sector council input, what I'm hoping for, I provided to Amy a list of our top 30 of the 90 occupations that are in the health science career cluster. And it would be very, very helpful for me if you could look at those 30 occupations and rank them 1 to 30, how important you find each occupation in your industry, or based on demand, what do you need the most of? And I will actually, Haley will be incorporating that data into the next round of the in-demand occupations ranking list. Our data, I think, is great, but it is lacking the qualitative side of things. Data can only get you so far. You need that qualitative information to really get things completely accurate. So that would be most helpful. Here is just an example. I put in some dummy numbers for the sector council suggested rank. They probably look insane, but just an example, like if you thought that licensed practical and licensed vocational nurses, which is ranked 7 in our total list of occupations, but for you, that is it's in the top 10 of things that you think are needed in the industry. Here I marked it as 10. Nurse practitioners, I had 1, but the in-demand occupational rank had them at 18. So just go through them, rank them just 1 through 30. Don't worry about trying to fit them into the in-demand, where they fit in the in-demand occupational rank currently, because there's 700 some odd occupations in there, and I don't want it to be overwhelming. But I'd really appreciate it. I think it would make a great difference in the quality of that list going forward. And that's all I have for you.
Thank you so much, Chelsea. I want to just emphasize how important this list is to the workforce and education system. We use it often in grant applications and program development to understand the current and projected demand in the state. And so your feedback really adds that qualitative perspective to that data analysis. So thank you for that, Chelsea, and thank you in advance to those that are here. I'll be sending that in the follow-up from this meeting. And Chelsea may
Much
reach
appreciated.
out to you.
Thank you all.
Yes. Yes, Jerry, go ahead.
We have a group of 6, but we have a state of 3 million. And so the perspectives would be colored by how many people answer the survey. And I'm wondering if you're going to end up with a sampling error by having such a small number of people replying to something with such a global importance question. So I think it'd be good to have a larger sample size of respondents to this survey.
I would certainly appreciate that. I think a lot of that sample error risk, which I think is a completely valid comment on this, will be filtered out because we're already using so much data to create the ranking, and this is not going to overtake all of that. But if I get a lot of feedback that registered nurses being number 1 is crazy, which I think is an insane example, but if that's where I was getting, then I would try to push it down just a little bit. But it wouldn't take something from rank 1 to rank 300 and something just because there's a handful of individuals that say that's not the case. But it's just to add another layer, more than it is to determine the entire ranking, if that makes sense, and hopefully puts you at ease.
Dr. Reeves, you bring up a really good point, and also just recognizing that the needs can vary to region, right? We've got northern, southern, rural, similar concerns, but not all the same. And we all know that we can't put everyone in the same box. Chelsea, have you thought about working with Nevada Works and Workforce Connections? They too have these business council meetings. That way it's a little bit more regional. And Joan, if you're on, I'm forgetting the rural RGA's name, but not trying to exclude them. Chelsea, we can help you with that. That way, to Dr. Reeves' point, which is a well taken point, we want to help you with that. So
Yes, I do appreciate that comment. We actually do separate this into regional groups already. So we do consider them in the rural counties versus Clark County versus Northern Nevada. So that's not lost on us here. I don't think we need a crazy large group on this. What I'm looking for is expert opinion on the occupational group, not necessarily regionalized. I just want to know from your perspective how it looks. I don't think we have to get too crazy in that perspective.
And we do, thank you for that, both of you. We do share, there are folks representing regional development authorities, chambers, and others on this call, and the Rural Health Network that Joan represents. She had to jump off, but she's coming back. And so we ask them to share with their networks too. We've done that with previous sectors. So great points. Thank you. So with that, I'll let that sit. Is that okay? Tom, do you have a quick comment? I want to make sure we get to partner introductions. Okay. All right. So I will recognize Marianne Segerson with the Research and Analysis Bureau with the Nevada Department of Employment Training and Rehabilitation. And I will share your slides for you. Go for it.
Thank you. I appreciate that.
Just
No. Okay. No, I can't see on this.
no, there we go.
Okay, cool. All righty. So I'm just going to go over some of our labor market information. This particular slide is just showing our state employment, and it is continuing to recover. Pretty much we have surpassed the February 2020 levels that we saw. And in this slide, the left column shows the net change in jobs from that time. And we can see that healthcare has added 4,900 jobs now. And Nevada as a whole has added 3,000 jobs over this period. The jobs in red, many of them have not recovered, like accommodation is still at 34,000. or down 34,000. Leisure and hospitality, I'm sorry, 34,000 for leisure and hospitality, and accommodation, 31,000. Righty, the next slide. So this just kind of shows that the green are the more recovered jobs, the red are the less recovered jobs. And we're seeing a shift towards higher wage industries. So just higher paying jobs. Healthcare currently is 3.9% above pre-recession levels. So one challenging aspect that this industry is facing nationally, that there are pretty much more jobs than there are people. So that's kind of an ongoing thing, both nationally and locally. And if you could go to the next slide. And this is just showing a comparison of Las Vegas versus Reno, and they're very similar in trends. And then we can move to our next slide. These are slides representing JOLTS data on a national basis. The job hire, opening, and quits have reached record highs in the health industry. And it's just basically showing a strong demand for labor. So the number of hire and quits are pretty much a good barometer for measuring confidence people have in the labor market. And currently, with this and our next slide, we're just seeing a lot of movement in the labor market. The arrows in these charts are representing the 12-month change. And the lines are representing like 2 openings equal 2 openings to 1 hire type thing. In our next slide, we have unemployment rate. It is now below 5%. The rate in June was 4.7, and we're ranked 49th in the nation. The US is still lower, it's at 3.6%. Next slide is our longer term employment in Nevada. And these are people who have been unemployed for like 15 weeks or more. And usually these folks are experiencing greater challenges re-entering the labor force. Our next slide is showing the labor force participation rate. Nevada is still below pre-pandemic levels. It's relatively lower compared to other states. It stands at 60.2. And the US is at 62.2. The last slide presented here is our labor force, just kind of various different type of long run changes. And it sometimes can represent economic trends. Overall, in conclusion, the health industry is continuing to grow. Our projections, we do have our projections for 2030, and it's projected to add 37,000 new jobs at a 3.1% growth rate. And we do, and I can provide kind of a write-up and summary of those projections if you'd like. Nurse practitioners are at one of the highest jobs with the highest growth rate at 5.4%. Also in the social assistance category, the substance abuse, behavioral health, and mental health counselors are 4% growth rate. In the nursing and residential healthcare facilities, chefs and head cooks are the top growth rate at 8%. Home health and personal care aides are at 6.7%. Within hospitals, physician assistants are having the highest growth rate with 4.3%. But overall, yes, I'd say nationally, the US is projected to grow about 3 million jobs through 2030. So definitely an industry to be watching and looking at carefully. That's about it for the labor market for healthcare. I could also share that report, the summary on the projections as well.
Yes, I will include that in my follow-up. Thank you very much.
Yeah, that'd be great.
A question that came in the chat is whether we have more current data than 2019. And I think that was referring to labor force participation. So there are different ways that this data is acquired through DATER. And so some of those are more current and some of those stretch back a little bit further. I'm not sure if you're able to quickly answer that question.
Is he or looking at the labor force participation?
Yes.
Do have
Yes, labor.
Yes, we can provide more recent data, definitely.
Great. Oh, okay. Yes, Jerry, thank you.
Is the rate of growth of the workforce faster than the rate of growth of the population or not?
That's a good question. Definitely, we are seeing some challenges with
Because I think that's what we care about is, will the healthcare workforce grow faster than the population need? If we stay behind that, we've got lots of troubles.
Mhm.
yeah, I think that's something. Does seem like there's a little bit of trouble there in my perspective.
Yeah, so
Definitely.
specifically, I can flag that question for follow-up. I think it's a really good one, and I'm sure that there's some accessible information that we can compile and send that out to this group. Yeah, thank you for that. We only have about 10 minutes left, and I don't see other questions in the chat. I do want to give folks that are present and the opportunity to introduce themselves, any partners in the room. So this is folks that work with the workforce or education systems, working on training to support the healthcare industry. All right, I'm going to put some prompts in the chat. This is a really important opportunity to share any resources that you might have available as solutions to some of the problems or challenges that you heard today. And in particular, if there are any events or specific opportunities to engage, that's something that would be really valuable to share here, as it will then be shared to the network more broadly. Yes, go for it. I'm sorry. Yes. Isis?
Hi, my name is Isis.
Isis.
I'm with the state of Nevada with DATER, with the Business Solutions Account Office. I wanted to let employers know that we do offer incentives at no cost to them if they're not aware of it already, but WEX, Silver State Works, for on-the-job training, stuff like that. We help with recruitment, hiring events, job fairs. I know in the near future, we're going to be putting together a job fair in the healthcare sector. I would like to include some schools in there also, like medical schools, because I've been out visiting a lot of them, and have them all get together.
That's great feedback. If you're able to provide some links to specific resources that you think would be most valuable, there may be some programs that folks aren't as familiar with and may not know what those acronyms stand for. So please feel free to put those in the chat, and I'll share them after the meeting. Thank you. Craig Stuckey.
Thanks, Amy. Good afternoon, everyone. Craig Stuckey. I'm the Director of the Office of Career Readiness, Adult Learning, and Education Options for the Nevada Department of Education. And I see a couple of my staff members have their hands raised, so I'll let them get into a little bit more detail. But our office oversees all the CTE programs in the K-12 space, including health science, which is what Jen Fisk oversees. And so in terms of the earlier conversation about educator shortage, we have the same thing on the CTE side in terms of finding properly licensed educators who can start our high school students on their health science career pathways. So I'll let Jen and Nancy get a little bit more detail, but earlier on, I did put my email in the chat. So if anybody needs to reach out to me, we're more than happy to answer any questions or talk a little bit more about what we're offering for CTE programs.
Thank you, Craig. Go ahead, Nancy.
Yes, good afternoon, and thank you very much. I oversee the adult education program through the Nevada Department of Education, and yes, Craig is my boss. I wanted to mention that for those individuals that need adult education services, we provide those services at no cost. We will frequently work with employers directly. So if anybody is interested in having assistance for incumbent workers, we can provide that with basic skills, English as a second language, but we also are working on occupational training through different grant funds that we have available. And a couple of our programs are really focusing in on the CNA area. So I will put my contact information in the chat, and certainly feel free to reach out to me for further information. I'll also put the information for our website for adult education where you can reach programs directly. Thank you very much.
Thank you. Go ahead, Jen.
As Craig said, my name is Jen Fisk. I work with the Nevada Department of Education. I oversee all of the high school CTE programs. So I'm looking for, currently we're redoing all of our standards. So the only one I have left is medical assisting if anyone is interested. But like Craig said, the teacher shortage. So just trying to find teachers that'll start them off at the high school level and then hopefully keep them here in Nevada and start that pipeline. But Jerry, I'm extremely interested in your VR headset. So if you need help getting into the high schools, please let me know.
Beautiful.
Good, thank you.
Thank you. And if I know you introduced yourself in the chat, but if there's a link or anything for that medical assistant program review or anything, I can send information in the follow-up, but I want to just make sure that folks know how to access that.
Awesome. Thank you.
Yeah, thank you. Any other partners interested? Go ahead, Shane.
Mute. There, I'm unmuted now. I can be heard. I am Shane Reeder. I am one of the newer training providers in the state. I wear a variety of titles. The easiest one to say is I'm a director in 3 different institutions. And we are a family of institutions delivering healthcare training in 3 different models. Charter College is an academic credit focused career school. Where that makes sense for Nevada is we're developing and we'll launch in January a RadTech program delivered in distance education with supervised field experiences. We'll do a similar model in Q2 next year with sonography and respiratory therapy. Charter Career Academy takes away all of the academic credentialing around our career training programs and takes that to a certification level. Nevada's currently approved us for medical assistant, phlebotomy, and medical equipment technician. And then our third model that's gaining a lot of traction and probably the easiest model for us to add programming is our registered apprenticeship programs. We have national standards for a variety of occupations, and we're building that in a registered apprenticeship and pre-apprenticeship model. Our programs currently that we're offering are biomedical equipment technician and medical assistant. in the works and soon to be launched community health worker, dental assistant, medical coder, and pharmacy tech. And we're working with employers across the nation to build those and bringing them into Nevada as well. And so we're headquartered, our family of institutions has been headquartered in Reno. We simply haven't delivered training in Reno in our existence. So we're glad to be part of the team.
Great. Thank you so much for that. Any other partners interested in making an introduction and sharing some opportunities or resources? I don't see anyone coming off mute. I did want to share one opportunity. I presented NEPRIS during the first sector council call, and we have an event series coming up in November, which is all around STEM. High Sierra AHEC is scheduled to present, but it would be really great to have others represented there for that series. So I'll include some information in the follow-up. And then we have a series at the end of September all around education. So there could be an opportunity there for all of you folks looking for teachers this is to speak to middle and high school students virtually, just 30 minutes or so about how wonderful it is to be in an education career in Nevada and how to get engaged in that pipeline, that pathway. So again, I'll share more information about how to get involved in both of those events. Before I move on, I need to ask if there are voting members that arrived after roll call that to introduce themselves, which I think we got. Jerry Reeves, Joan Hall was here, and that was it. So we're all good there. And then the final item before we adjourn is agenda item number 9, which is public comment. And although many of you have had the opportunity to share, this is the required public space for other members of the public to provide a comment. As a reminder, no formal action may be taken on any issues not included in the posted agenda. Public comment will be limited to 3 minutes per person. So you may now raise your hand to be recognized for public comment. Okay. One sec. Oh, Siri wants to make a comment. I don't know how that happened. All right. So hearing no comments, I will move to adjourn this meeting. And I just want to thank you all again for your incredibly valuable and thoughtful participation. I will be sending follow-up very, very shortly and look forward to seeing you all again together in 3 months.
Thank you.
Thank you very much. Take care.
Bye, everybody.
Thank you, Amy.
Thank you.